fearless leader, uh, Andrea.
Yeah, hi, welcome everyone. I am Andrea Whitwer. I'm a psychologist here at the Nysonger Center and lead the Building Bridges Project. And I will popcorn it to Erin.
Hello, I'm Erin Harris. I am a uh, clinical social worker at the Nysonger Center, doing many things, and hub member on this Echo for quite some time, and also owner of private practice therapy called Thoughtful Growth Therapy. I'm gonna send it over to Ashley.
University Night Center's Go on evidence-based psychotherapy for adults with intellectual and developmental disabilities. In our first session, we'll be hearing from Dr. Andrea Whitwer, a clinical professor in the departments of psychiatry and behavioral health and psychology. She is also the director of our LIND graduate program here, as well as our director of training and outreach. In today's session, she will be talking about ethical principles in the treatment of this population. And ambitiously, we want you to be able to understand and apply some ethical standards in the context of treating individuals with intellectual and developmental disabilities, some recognition to mitigate diagnostic overshadowing, be able to promote informed consent and assent practices, identify and address ableism and implicit bias, be able to center the client's voice in ethical decision making and consider implications of guardianship. So at this time, I welcome to the stage Dr. Whitwer. She's going to share her slides and take it away.
Yeah. All right. Hopefully everybody can see my slides. Pull up so I can see everyone's faces here. I'm so excited to see all of you. We have been really excited to work on this community of practice together. I'm going to talk about all of these learning objectives, I promised. But I think since this is our first Echo, I just wanted to do a little bit of background information just on why we're doing it, kind of level setting us all on like what we know about mental health, what we maybe don't know yet, and let you know kind of how this whole curriculum was pulled together. So I'll do that really fast so we can get into the fun meat. So one of the reasons why are we all here, we know that individuals with intellectual and developmental disabilities are more likely to experience those life events that put them at increased risk for health problems or mental health problems. So just kind of the nice thing to kind of think about here as we level set, think about those risk factors, as well as realizing those rates. We know that because of the increased risk, we see the ranges are pretty broad, but we think somewhere between 10 to 60% of adults with ID have some type of mental health condition. And for example, they're 3 times more likely to experience depression. And we also know this is the case with children and adolescents as well. When we look at what those rates are of different disorders, we see high rates of ADHD, major depressive disorder, generalized anxiety disorder, social phobia, substance use, but just that increased risk we see in their increased risk factors, as well as just that overall increased risk, 5 times greater than those. So that was really the driving factor for the development, not only of this Echo series, but of our Nysonger Rehabilitation Research and Training Center grant, which is really this idea of focusing on adults with intellectual and developmental disabilities and understanding how can we assess mental health, and then also how can we identify best practices in mental health treatment. So kind of the building to get to the point of this curriculum was a systematic process where we started with just looking at the current state of psychotherapy research. We know that there's increasing research that says that psychotherapy can be effective for adults with intellectual disability. We've seen a number of randomized controlled trials that are showing positive results. But there's really not like a consensus guideline out there. We don't have a big enough body of research yet to be able to say this exact treatment should be used for this these pieces. So this puts therapists in a rough spot because we have a whole population of folks who are at increased risk for mental health. Hence, this idea of really trying to figure out what are those practices that therapists can use within their research that are in their practice that are being used in research. So another paper that we did was really doing a scoping review to understand what are all of the different types of accommodations and practices that were being done in the research, so we could really understand that, pull those together. We came up with a lot of themes, but as you all are maybe sitting here shaking your heads or thinking about, well, that's great, research is one thing, but therapy is a different beast. That's why we then did focus group research, where we talked to first therapists that were out in the field saying, these are the things happening in research. How does this line up with what you see? And then did focus groups with adults with intellectual disability to get their take on the practices that were being done, the things that they thought helped therapy go well, the things that were challenging. We don't have time to show this awesome video that actually our fabulous Andrew Buck pulled together, summarizing all of our research, but you should have access to these slides. And I didn't tell Manisha and Andrew I was going to ask them to do this, but maybe they could. Oh, Andrew's already putting it in the chat. I should just know that he is totally on top of things at all times. So you can look at, I'll even say, these papers were published open access, so you can look for those actual papers. We also have clear language versions of these papers on our What Have We Learned So Far products website. But we really wanted to pull this together so that we could think about, again, there's not like a set of guidelines that we can match certain therapies. So how can we arm therapists with what they could use given their skill set, given the clients that they have? So together with our group of disability experience expert panel, so Ashley said she works on a lot of projects. This is one of them. We have and Christine Brown as well, along with research experts, helped us pull together practice guidelines for psychotherapy. So basically, it's a whole document on tips and practices and things that are a culmination of all of this research, which is what you're going to kind of hear about broken down over the next few weeks with our ECHO. So that's the background. Hopefully you kind of see, okay, these people, this is the background they're coming from. This is what we know. I'm hoping, as we said, this is a community of practice that we can all share together. But with that, because I'm already running out of time, I'm going to dig into the ethical aspects of this. So that's really kind of level setting with therapy. I'm not going to kind of do a didactic on all things ethics, but what you're going to see throughout my potential ethical situations that I'm going to bring to you are these themes of respect for persons, both autonomy and self-determination, making sure that people feel free from control or influence, the ability to make informed decisions. How does beneficence and non-malfeasance play out in this population? What are the things we need to think about? Justice, as well as others. So this is there to kind of help us think about it, but it's not quite, it's sometimes, again, there can be some ethical tricky situations in this group that maybe aren't always clear cut. And so I'm going to walk you through, I kind of think of as the clinical pearls with some of these. So things like informed consent and assent, guardianship, watching about that ableism, really thinking about that self-determination and how to center the client's voice, thinking about questions of your scope of practice, as well as some others. So I think we kind of get into this idea of guardianship. When we look at a national survey, 53% of adults receiving services reported having a guardian. So that's kind of one of those important pieces for us as therapists to think about when an individual comes in is, are they their own guardian? Do they have another guardian? Because that's going to be important for informed consent. But I think the idea is that it's 50-50. It can go either way when we look at that guardianship piece there. So one, important to clarify. And I think also important when we think about those questions of guardianship. I know as I've worked with so many fabulous adults with intellectual disability over my career, I think back to when I was a brand new psychologist and I get these requests to fill out guardianship paperwork. And I would sometimes think, oh, of course I should fill this out for everybody that comes across my desk. And that's not always the case. Sometimes there are different types of guardianship that may be more appropriate for someone, or other less restrictive environments. So I think it's really important for us to think about, from our perspective as a clinician, if we're filling out that paperwork, but also our clients, and realizing there are a lot of different less restrictive alternatives. I've listed some of them here. There are a lot of them. It's really important that, you know, if we're supporting decisions around this, that we look for that least restrictive option that might be there. And I will say that Disability Rights Ohio is a fabulous resource for this. Their section on alternatives to guardianship and guardianship are a really nice place if this is something that you haven't really dug into. The next area is looking at informed consent and assent. So what we need to think about, what if someone is their own guardian, they're going to be filling out their own consent, right? So informed consent to provide treatment, etc. Thinking about releases of information, all of these other pieces. So it's really important that these be presented in a clear and accessible way. Sometimes those informed consent forms are not great. So can we provide a clear language version, looking at size, the font? Another thing that we've seen that folks have said that's helpful is to give folks time to think about it. So maybe sending something like that ahead of time so that the individual has times to ask questions about it. Again, determining who that guardian is. There may be someone that's acting as a guardian that you have to get that paperwork signed before you see the individual. So doing that work. The other piece, though, is that even if the individual is not their own guardian, assent is so important, right? We want to give autonomy whenever we can. So we want to make sure we include assent that should also be, again, presented in that accessible way. The other thing that within this piece that our team has really zeroed in on, and it was a lot of those conversations during the focus groups too, is the importance on really providing explicit information on privacy. They may assume that they have to share things with their other team members. They may not know they have a choice, right? So you think about some of our ideas on releases of information. Typically, if someone brings someone to therapy with them, it's implied consent that things be talked about in front of them. Sometimes adults with ID don't realize they have a choice. So in our clinic, even if someone accompanies them, we have that person sign a release of information so that they realize they have a choice of whether the person is there, whether they're sharing information across their whole team. And of course, there's some things to navigate with referral sources, funding sources, but I think having those explicit conversations with the adult themselves is so important. The other things that we realized is that this should be really an ongoing and iterative process. So having this dialogue that you're asking the client questions, checking in with any concerns that they have. Same thing with that release of information. I think we heard from our focus group participants, yes, I signed the release of information, but then later on they'd be like, but I didn't really want to share that with the person. So helping them realize they have some of those choices is just something we want folks to just be checking in as we go throughout. The next one is guarding against discrimination. And I think this is something that, as clinicians, we all guard against, but I think thinking of it from that realm of ableism and just really paying attention to either explicit or implicit biases that we may have, maybe based on a client we had, where we are in our careers, how things were talked about, said, the words that were used. Those things are so important. And I think also really being mindful of potential microaggressions or things that can come off as condescending language. So like calling an adult buddy, maybe non-verbally patting or treating them in a way that might infantize them. You see on my slide a few examples where an autistic individual was rocking and was basically kicked out of a group because they said it was distracted, or a clinician that really felt the individual could do things but was pretending. So I think believing and listening to adults with ID is such an important piece. When I hear different steering committee members of projects that I've been on talk, it's like, if someone just listens to me and believes me and hears what I have to say and respects me, it goes so far. Which leads us to that respect piece. I think it's this, and I think this is this piece of monitoring throughout, right? We want to treat adults with ID like we'd want to be treated, and really watch the language we're using and whether we're maybe slipping into things that might make them feel as though they're being treated as inferior. So one of those, I think this was like a great nugget that was advice I was given, is take the time to understand their perspective and what's important to them, right? This might be taking a bit more time, but really valuing that and showing them that you value their thoughts, what they think is important, is so important. You're going to hear about using things that are accessible, all this. We want to use plain language or clear language, but we still want to talk to an adult. We don't want to talk to someone as if they are a child. But I think it's balancing clear language with not using things like infantizing or more not developmentally appropriate language. The next clinical pearl is this whole idea of diagnostic overshadowing. We think of this, diagnostic overshadowing happens when, and we see this with clinicians, with direct support staff, family members, where everybody just assumes that all an individual's behavior, challenges they're having, are all a part of their intellectual disability, a part of their autism, a part of something else, and not realizing that there's a co-occurring mental health condition. So this can just be something that as a therapist or as a diagnostician, we have to pay attention to, both from like a diagnosis perspective as well as a treatment perspective. Maybe this individual, while they're not getting out and doing things, and yeah, they need to build their adaptive skills, they're depressed and they really could use some behavior activation. But if we're just thinking about building adaptive skills and not thinking with that treatment lens of their mental health diagnosis in mind, we can really kind of miss the boat. So I think it's an important piece to know from that perspective, as well as that psychoeducation of that individual's family members, team, etc., that this is a mental health condition that this person has. This is not something that's secondary, that's a part of their autism or their other disability. The other piece is scope of practice. And I think this is, we're going to talk about a lot of different practices, accommodations, and approach. And many of these can be used with a skilled clinician, even if they haven't had maybe a lot of specific training. But there may be some time when cases are referred out that need to be referred out. But I think I challenge folks, when we think through that justice lens, we don't want to just refer everyone out just because we see a diagnosis. Odds are you are all here. I may be preaching to the choir, but we don't want to just refer everyone out because they have a diagnosis. We know there's a small group of therapists that have been trained in this, and it's a small group that are willing to take folks. So when we automatically just say no, it really reduces access significantly. I'd love to hear in the chat if, like, when would you refer out? When are things where you think you might need to refer out? If you want to kind of just think about that as we think about that for conversation. We want to look at making sure that we're choosing appropriate materials. So things that are based not only on the individual's language level and cognitive level, but also their age. Wanting to really think about their maturity and experience, find things that are accessible and appropriate, but not inappropriate based on their age. and I think this is kind of my last ethical clinical pearl, is prioritizing the client, which is easier said than done. When the client shows up with direct support professionals or their behavior support team or a parent, how do we manage all of those? Make sure that we're talking to the client, thinking about that. It might take having a separate meeting with the staff after talking with the client to provide psychoeducation, et cetera, but really being thoughtful as you're thinking about your therapy, that who your client is and how you're serving them. We're going to share a ton of, I'm going to go to questions in a second beforehand. We're going to share a ton of resources. One of my favorites is something called the Link Center. This is a center that's, the goal is really to improve access to mental health services for people with a range of disabilities. They have a huge resource library with all things that you can look at. They also have shared learning groups quarterly on different topics. They have projects and provide technical assistance. So I encourage you all just to look. Their clinical resource tools are fabulous. They work with a group of researchers as well as a steering committee. You see our steering committee picture on the right that helps to form the materials and think about how they can be practically used. They already talked about this and we've got the link, but another plug for our own project and some of our tools. We have a lot of different that you're going to hear about, my mental health toolkit and other tools that you all can use. So you're welcome to kind of peruse them now, and we'll touch back on them as we go through. And then with that, I think I'll just pause and see what types of questions you all have.
Thanks so much, Dr. Whitwer, for sharing that information. I mean, for me, the big nugget, the foundation of this all is the dignity of the individual, right? When we think about ethics, and we've talked to, as you've referred to, our disability experience expert panel. When we think about ethics, we think about fairness and fair treatment, and of course, the golden rule comes up. But it really does come down to, right, this human dignity, and providing those individuals with the respect that they deserve. Something did come up, and I think you did kind of touch on this. I'm wondering if you might have anything else to say about clients who have a guardian with power of attorney, and maybe navigating those issues. I know you were kind of talking about having those conversations together with people. Anything else that you'd like to add about that scenario?
Yeah, it might be helpful to hear what the specific
Hmm.
questions are. I think, right, when we come down to if someone has a guardian, if there's power of attorney, we've got to follow those rules when it comes to making sure they're consenting to treat, et cetera. But I think it would be helpful to hear from that person if they've got specific
Yeah.
questions related to that.
Yeah,
Um, it,
Elizabeth.
it was my question. And Becca, feel free to chime in if you have anything you would add because you know who I'm talking about. Yeah, this client is they're an adult, but they've just turned adult recently. Parent has power of attorney, was present at the first session with the client, but afterwards, I've been seeing the client one on one. And so I just kind of want to like know a little bit more about the nuances of that. Becca, is there anything I should add about that?
I don't think so, Elizabeth. I think, are you asking about the nuances between like power of attorney and then also guardianship?
Yeah.
Okay.
I might also look to some of our hub members just to see if you have, yeah, experience with navigating
Oh,
those nuances.
I'm sorry. I should also add that I mean the guardian is willing to like work with the client, but I would say the client and the guardian actually kind of have different goals for the client um that are kind of like a little sticky to contend with, but I'm just navigating by trying to keep them both happy while still honoring the client.
I see Patrick's kind of putting a great, my experience is I have to create a relationship with the family, the guardian, because they may have trust issues with service providers by history. So I think it is like having that conversation about clarifying what everyone's goals are. And then making sure you're on the same board. But I think it's reasonable to communicate, the person is here, we want to honor their goals, and then kind of talking about that. And maybe part of it is just helping the team navigate what those look like. And I think, I don't know, Patrick, if that whole idea of like setting that relationship with the guardian, like you're not trying to undermine said guardian or take sides, quote unquote, but just basically kind of everyone's goal is to move the person forward.
Yeah, I would also say that with especially younger folks or transition adults, there's unfortunately, I don't know if I want to say they're externally motivated rather than internally motivated and prompt dependent. So it's almost having to train everyone or teach everyone about the independence that they have in making basic decisions, if that makes sense.
No, it definitely is. This is actually something that came up in group supervision last week about this client. I will add that I did not know the client's goals until I met with them one-on-one. So because the client kind of had the parents speak more for them the first time that we met. So now after meeting with them one-on-one, I know that their therapy goals are different from their guardian, what the guardian would like them to do in therapy.
Erin, did you have something to add?
Yeah, well, I did, and then I lost it because the conversation was so great. I think just, seconding what Patrick has shared, I think you said they recently turned 18. I think anytime somebody is turning 18, whether guardianship or power of attorney is considered, having a team, like a meeting with guardian and the individual to just talk about, like, legally, what are the expectations, what are the boundaries, you as a clinician, what are your what are you bound to as a clinician, to make sure that everybody is aware of what those expectations are, and just reviewing consent and all of that stuff together, and really making sure the individual understands their rights, even with a power of attorney or not. Because like it's already been said, a lot of times individuals just automatically will, turn to parent, turn to, person of authority to answer the question, and they may not realize that they don't have to do that. And that, it might help them be able to express their goals a little bit more clearly, and help, parent understand where they're coming from.
Thank you.
Wow. Well, I mean, we're not shying away from the complexity of, right, the issue at hand here. And this is why we're all coming together, and really appreciate everyone even just being vulnerable. Like Lauren here in the chat is just asking, sorry about the basics. That's okay. We need to get down to the basics. Does anybody have just a clear explanation of the difference between legal guardianship and power of attorney? I think oftentimes they go hand in hand, but sometimes they are different entities.
This is Christine Brown. I could share with you all that my family and I put power of attorney of healthcare, springing durable power of attorney of finance, which means I'm my own payee until I can't be it mentally one day. I can be honest, but this has nothing to do with being DD, okay? So many of us see cases being victims on like fraud on your bank accounts or things. And it's like, just because you see that does not mean you're incompetent handling your money, okay? Because the world is full of scams and everything, okay? And so the thing is, we have had this power of attorney of healthcare. So if I was was having to go through things and I couldn't talk because I was going through anesthesia, okay, and or I needed help understanding this procedure, like just because you can't know what should you have this certain medical procedure done, what's the pros and the cons, okay, is important to learn in part of medical decision making, just to say. But we have, for some of you who don't know, because I'm co-chair our disability experience expert panel, we've created the My Mental Health Toolkit, and it has tools like saying how does the person communicate, what are their sensory needs, and lots of other things. There is, of course, a big focus, and it just keeps getting up and down, the supported decision-making law that we're hopeful to have that get passed. And because you can't say that an 18-year-old, because they can't manage their money, requires a guardian of finance, because I don't think any of you are pros at 18. So it's like, can't say that because you can't handle your money perfect at 18, you require a guardian for finance. No. So it's part of a learning curve, that's what I will say,
Yeah,
because they need to know that nobody's perfect. And so they all have their own learning styles.
right. Yeah, thanks, Christine. I did a little bit of, looking around too, and I think, one of the main difference between it is legal guardianship is more of a court mandated authority over another person based upon, um, you know, some incapacity that's perceived of the individual, maybe their disability, maybe that's the cognitive disability, where power of attorney is more of the individual themselves designating someone. So there is kind of a difference there in sort of the level of power over a person. We talk about that school to guardian pipeline where young transition aged youth emerging into adulthood and then are often placed on guardianship encouraged by schools, and we saw some of that come out in the comments where there's a lack of training. There's a push for parents to take over guardianship, and so this is one of those issues. And something else that came out was the conflict really comes down to the individual and the legal guardian or the power of attorney have different goals in mind, and so that does not set up for a beneficial therapeutic outcome when the individual does not share the same goals as their guardian. We have just a little bit more time. I see Vanessa has her hand raised and then Ashley. Vanessa?
Sure. Sorry, I'm not showing my face. I'm still in my junkies because it's my day off.
That's okay.
But I would say, I think having done this for 40 years and worked with lots of quote kids, that I start seeing it as kids and follow them into their 20s and 30s and now 40s. And it is so essential if you have someone who can get to know the whole family and continuously get the family on the same page as the individual about goals. It just makes the whole process of guardianship, power of attorney so much clearer. Whoever said, I think in the chat, that power of attorney is what I give to my husband when I'm going into surgery. So if I can't talk to myself, and that's something that you give to someone, where guardianship is something where a court, as you said, takes away some individual rights, but ideally it's been worked out cooperatively. So everyone knows the guardianship, and there's different kinds of guardianship. There's guardianship of finance in Ohio, at least, and there's guardianship of person, and those can be different. The other thing about Ohio, and I've learned this just recently, is the guardian has to be in Ohio. I've had some complicated situations where the parents are elderly, and the nearest person who will take guardianship is a relative who's very close, but they live out of state. So having to think creatively about How can you have a local guardian do certain things and handle certain things? Maybe it's an agency, maybe it's a person or a person in an agency, while the person who knows and loves the person guides the guardianship in other ways. So I think my main point for me, at least in some of these really complicated cases, especially where the individual is very capable in many ways. They even live alone. They make a lot of great decisions for themselves, but in certain ways, especially financial, they can admit that they can't manage that part. To think creatively and as cooperatively as possible, which means a lot of meetings, a lot of sessions, a lot of shared meetings, and working with the 3 or 4 agencies that are involved gets very complicated. But I appreciate what you're doing, and I want to thank you.
Thanks for sharing that, Vanessa. We've got a really healthy chat going on as well, people sharing resources and strategies. So again, continue to be engaged in that. Ashley, you had something to share?
Hi, this is Ashley. I think guardianship shouldn't be jumped immediately. Obviously, if the situation arises that obviously there's some challenges they need to have a guardianship, yes, there are some situations guardianship is the appropriate answer. I'm sorry, I was 18 years old. I didn't know what I wanted and I didn't manage my money, right? I think we were teenagers and especially in my early 20s, I kind of blew through money. But that being said, that's any neurotypical developing. My mom called the 18 to 21-year-olds just the time of their life. Don't want to listen to adults or guardians. That's just normal. We're out of high school. We think we know everything. But that being said, power of attorney is something I have myself. I have to update it. It's a little old, but I'm updating it. One of the situations Vanessa's brought up, I originally was going to have my younger brother be a power of attorney on my stuff. He's in the army and going to special forces. And it's not appropriate because there may be some situations where he's off the grid and we can't get a hold of him. So I am picking people here locally. My parents are going to be there for power of attorney purposes. My mom's a nurse, so she's going to be healthcare. My stepdad and my sister. But that's a very good situation where, with my brother being in the military, I said to him, "You were my first choice. You're married and you're going to be on so many different bases that I can't get a hold of you on your phone, and this is not something I want to go off the chain of command calling you for. Sorry, love you, but I'm not." Um, but I think, support decision making should be brought up. Power of attorney, guardianship. With guardians, that relationship can be a little tense if the individual is not receptive to the guardian or guardian's not receptive to the client. With that being said, we sometimes have to work as a team in this field. It's one of those, we work together as a team to help not only the individual, but also how can the team work together and help them as well. Guardianship just gets such a bad rep because everybody assumes with guardians, you're going to steal their money or just the bad association. One of the things I bring up in the news is the Britney Spears conservatorship. That's just what people hear it. They think of that situation. That is very rare. It does happen, but that's not what guardians are there for or conservatorships. But I just think at 18 years old, thinking go jump into guardian. Well, the schools unfortunately lack the training. Hopefully, maybe down the road we can change that. There are some situations just guardians are appropriate, not all of them. And plus, she's 18. We're 18 years old. I don't think any of us at 18 knew what we were doing or had the maturity level. I'm sorry, I didn't.
Yeah,
I
thanks,
didn't
Ashley.
either.
Yeah, right. I think we can all echo that. And I think what you said right there at the very end, how, in some cases, maybe it is the best scenario. But I think, again, it comes down to the uniqueness of every individual and providing that dignity. And, again, even coming from this question of, do we have to check with our clients? Do we accept self-report? And then somebody also said, well, this is kind of part of our protocol. This is part of our intake process. We get at guardianship and power of attorney and try to get people on the same page because, we know that therapeutic outcomes are going to be better when the client is consenting and it's their goals and their purpose to be there. We're running short on time. I really wanted to maximize our time with Andrea today. Are there any other questions that anyone would like to ask Dr. Whitwer? She has to hop off here for her next meeting at 1 o'clock. I just wanted to see if there are any other questions. And again, let me throw out a kudos to the community real quick. This is our 5th series of doing these sessions. And I just want to give you all a pat on the back, or you can give yourself a pat on the back, that this is one of our most interactive and engaging first sessions that we've ever had. And I think we're really doing ourselves a great service by being here and engaging in questions and sharing things in the chat. Really appreciate you taking the time to be here and build this community together. Christine, you have your hand raised, and then we'll maybe get final words from Andrea.
Okay, I saw Jeff Marine Shrivers is on here. He had that guardianship restoration book that we've created. Maybe it's something to share, Jeff, only for sample. Don't use it yet for all of you to see, because he and Arc Industries, before they changed to Voyagers, okay, did the guardianship restoration class, and one of our friends who's in my deep got her guardianship back. And personally didn't even have to go into court, but I think it's because it was COVID, really. But that's something to share, just for you all to know, because if somebody out there in your practice got guardianship of 18 just because the parent was told, oh, you need to have them take guardianship, but they're 30. If we ever got some pilot and program to make more people who could get taught about this, getting their guardianship reversed someday, it would be great. And after the supported decision-making law goes into effect, it would be even more enforcing, just to share that. I don't know,
Christine.
Jeff, if you want to say anything of that book for just a second. If not, okay.
Yeah, if there's a link or you want to share that out as a resource, we will house those. We're going to transition here with time. We'll kind of bring that back up. But again, let me send it back over to Andrea for any final thoughts, and just recognize you as the mastermind behind this Building Bridges Echo series. And so thank you for bringing us all together and creating this community. It's kudos to you, and really a testament to your passion for improving services for people.
Well, thanks. I'm so excited. Like I said in the chat, you are an awesome group. This is going to be such a fabulous community of practice. I'm so sorry I have to log off early. I will be back for most of the cases. But I think we're going to all learn, and we're going to all learn together, right? That whole learn all, teach all is fabulous. I think as a community, we can learn from one another. I'm just really excited for the session. So thanks for showing up, and I will see you guys at our next session next week.
Sounds good. See you soon. All right, so that will transition